This is Sarah Alsis, and welcome to my presentation on adrenal disorders in childhood. First, just a quick A and P summary. Your adrenal glands lie on top of both kidneys and function within the endocrine system. Each adrenal gland is made up of two sections, the outer cortex and the inner medulla. The inner medulla is responsible for the secretion of catecholamines, which aid in the fight or flight response, and the outer cortex produces steroid hormones. The mineralocorticoids help to regulate salt balance, blood pressure, and renal blood flow. The glucocorticoids influence protein, fat, and carbohydrate metabolism and help to regulate the body's stress response. The release of hormones is attributed to the hypothalamic pituitary adrenal axis. The hypothalamus secretes corticotropin-releasing hormone, or CRH, which then stimulates the pituitary gland to produce and secrete adrenocorticotropic hormone, or ACTH. ACTH then acts on the adrenals and regulates the release of the catecholamines and steroid hormones. This system operates within a negative feedback loop. When the body senses enough steroids or catecholamines have been produced, it then acts as an inhibitor to the production of additional ACTH and CRH. The main disorders affecting children related to the adrenal glands include primary adrenal insufficiency, or Addison's disease, secondary adrenal insufficiency, congenital adrenal hyperplasia, hyperadrenal states such as Cushing's syndrome, and adrenal tumors, for instance, neuroblastomas. Addison's disease is a type of primary adrenal insufficiency and occurs when there is a deficient amount of cortisol and aldosterone due to an autoimmune destruction of the adrenal cortex. A lack of aldosterone means the kidneys will be unable to excrete potassium or retain sodium and water in order to maintain adequate blood volume and blood pressure. Deficient levels of cortisol means the body is unable to raise blood glucose levels via gluconeogenesis and incapable of blocking the release of inflammatory substances in times of stress or illness. Patients with symptoms of primary adrenal insufficiency will present with a history of a failure to thrive, weakness, vomiting, hypotension, dehydration, lethargy, or an altered level of consciousness, and/or skin hyperpigmentation, which is due to ACTH overstimulation of melanocytes. Diagnostic indicators will include a metabolic acidosis, hypoglycemia, hyperkalemia, hyponatremia, and a serum cortisol value greater than 20 micrograms per deciliter. Management of Addison's disease includes a referral to pediatric endocrinology and lifelong daily replacement of the deficient mineralocorticoids and glucocorticoids. An acute adrenal crisis necessitates immediate IV fluids, IV dextrose, and stress doses of hydrocortisone succinate. Parents of a child with Addison's requires education regarding the administration of steroid stress doses should their child become ill, febrile, or undergo surgery. Parents also should be taught how to recognize the symptoms of adrenal crisis. Children with Addison's disease require close follow-ups of their height and weight for growth tracking. Secondary adrenal insufficiency is when there is a deficiency in only glucocorticoid production, either from lesions or tumors in the pituitary or hypothalamus, an ACTH deficiency, central nervous system trauma, cranial radiation, or possibly due to suppression of the hypothalamic pituitary adrenal axis from chronic steroid use. Clinical findings of secondary adrenal insufficiency correspond to the symptoms of primary adrenal insufficiency. These include fatigue or lethargy, poor weight gain or failure to thrive, weakness, or nausea and vomiting. Patients with secondary adrenal insufficiency may present with pale skin due to ACTH low levels and the corresponding understimulation of melanocytes. Diagnostic evaluation includes an abnormal ACTH stimulation test, hypoglycemia, and possible signs of dehydration. However, sodium and potassium levels will be normal as there is no defect in aldosterone production. Referral or consult with a pediatric endocrinologist is suggested for treatment and disease management. Patients with secondary adrenal insufficiency produced by radiation or from other permanent causes will need lifelong cortisol replacement therapy. Others with a reversible form may only need cortisol replacement until the causative factors are resolved. Daily and stress doses of hydrocortisone are similar to primary adrenal insufficiency dosing. Congenital adrenal hyperplasia is another type of primary adrenal insufficiency caused by a deficiency in one of the enzymes that makes up the cortisol pathway production. The most common defect is a 21-hydroxylase deficiency, where cortisol precursors are shifted to the androgen pathway, which produces female infants with ambiguous genitalia from the excess androgen exposure. Male infants may only present with a mild penile enlargement or skin hyperpigmentation. All newborn screenings in the U.S. are assessed for this classic congenital adrenal hyperplasia, or 21-hydroxylase deficiency. As congenital adrenal hyperplasia is a type of primary adrenal insufficiency, its symptoms will mimic those of Addison's disease. They include dehydration, vomiting, lethargy, poor feeding and failure to thrive, hypotension, a metabolic acidosis, hypoglycemia, hyperkalemia, and hyponatremia, and an elevated serum cortisol level. Referral of care to a pediatric endocrinologist for patients with congenital adrenal hyperplasia is recommended. Patients with congenital adrenal hyperplasia need lifelong hormone replacement and possible exogenous salt replacement therapy. Serial monitoring of height and weight is advised. Parental education and support surrounding correctional surgery for females and the importance of cortisol stress dose administration is emphasized. Cushing's syndrome is a state of cortisol excess. Excess cortisol can be due to an endogenous source, such as an unregulated feedback of CRH and ACTH, pituitary or adrenal tumors, or from an exogenous source, such as too much steroid administration during the course of an illness. Clinical symptoms of Cushing's syndrome include excessive weight gain, especially in the face, back of the neck, and trunk. Pediatric patients may also present with signs of slowed or delayed growth, osteopenia, muscle weakness, excess hair growth, purple or reddish colored stretch marks called striae, and a possible lability in mood and affect. A 24-hour urine can be collected to evaluate for free cortisol levels for diagnostic purposes. A distinguishing characteristic of Cushing's syndrome in pediatrics versus adults is that there will be a slowing in vertical growth while continuing to gain weight. If children have received an exogenous source of cortisol for greater than 7 to 10 days, it is advised to slowly wean the steroid dose rather than abruptly discontinuing in order for the recovery of the hypothalamic pituitary adrenal axis. A slow wean of the steroids also prevents a flare-up of the underlying disease process. If excess cortisol levels are due to a tumor, then surgical removal is needed, followed by daily oral cortisol replacement. Patients with Cushing's syndrome will also benefit from a consult or referral with pediatric endocrinology. The most common pediatric adrenal tumors can be classified as benign adenomas, functioning tumors, which include aldosteronomas and cortisol-producing tumors, and lastly, malignant tumors or neuroblastomas. Adrenal cancer is most likely to affect children younger than 5 years of age. Neuroblastomas are the most common type of pediatric malignant tumor that arises from the adrenal glands and is the third most common pediatric cancer after leukemia and brain tumors. They are also the most commonly diagnosed malignant tumor in the neonate population. Pediatric patients with an undiagnosed neuroblastoma may present with complaints of a firm, non-tender palpable mass in the abdomen, abdominal ascites or dependent swelling in the legs, irritability of the patient, complaints of bone or joint pain, or refusal to ambulate. Diagnostic imaging includes either a CAT scan, ultrasound, or MRI for identification of an abdominal mass, and adrenal biopsy for confirmation of diagnosis. Treatment of neuroblastomas includes first a referral to pediatric oncology for surgical removal or resection, along with chemotherapy and radiation management. Support for the patient and their families is crucial, as treatment can be lengthy, prolonged, and painful. Education regarding treatment options is essential, together with emotional reassurance along every step of the process. Survival rates for neuroblastomas are higher when detected early. An infant under 12 months of age has an 83% 5-year survival rate, compared to only a 40% 5-year survival rate if diagnosed after 5 years of age. For anyone who desires further information, additional resources can be found at the National Adrenal Diseases Foundation website, the Pediatric Endocrine Society website, and at the American Academy of Pediatrics website. Thank you very much for your attentiveness, and I hope you enjoyed the presentation.